Welcome to SSM Spine Education class. You're receiving this information because you're scheduled for an upcoming spine surgery. Please watch the video to the full extent, then reach out to your spine care team if you have any questions or concerns. As we navigate through the agenda today, please keep in mind that there are several surgeries that will be discussed throughout the class. Not all slides and information will pertain to the specific surgery you are having. Please ensure you know what specific surgery you are having before you continue to watch. As far as our agenda, we will discuss the anatomy of the spine, briefly describe the surgeries, what to expect before and after surgery, what our expectations are from you, your pre-admission and admission process, lifestyle changes for optimal outcome after surgery, pain, knowing that you will have pain after surgery and how to manage it, and discuss your discharge plan. Let's break the spinal column further down from there. Please refer to the picture on the right when we're discussing each section. The lamina of each vertebrae forms the back portion of the spinal canal. Your surgeon may perform a laminectomy, where they're removing a partial piece of this bone or the entire bone. A foramen is the small opening between the vertebrae where the nerves leave the spinal canal. You may hear your surgeon say you have foraminal stenosis, which is narrowing of that foraminal hole where those nerves come out. The vertebral body is the building block of each spine, and the discs serve as the cushions between the vertebrae. The discs are the soft center that absorbs shock during movement. This allows each vertebrae to move side to side, allowing the body to move more freely. Common spine problems, or maybe the reason you're seeking treatment from your spine surgeon. Disc degeneration. As we age, discs may collapse or degenerate. As the disc wears out and begins to collapse, pressure is put on the nerves. Bone spurs may grow where the vertebrae rub against one another. These may cause narrowing of the spinal canal or stenosis, putting pressure against those nerves. Spinal canal narrowing can result in pain, weakness, numbness, and/or loss of coordination. Depending on the severity of the pressure placed on the nerves, weakness, numbness, tingling may remain after surgery. Disc herniation, slipped disc, or ruptured disc is when a portion of the disc pushes through a crack in the tough exterior of the spinal column. Bulging discs are part of a normal aging process. When the bulging disc compresses a nerve, it is when it becomes a problem. Herniated disc can be putting pressure on the nerves, resulting in pain, tingling, numbness, or weakness in arms or legs. Nerve pain is pressure caused by damaged discs or bone spurs that may cause numbness, tingling, and/or pain. Common spine problems continued. Spondylolisthesis, as pictured on the right, is when a worn-out disc allows a vertebrae to slip forward. This may cause pain, numbness, tingling, or weakness in the arms or legs, depending on which level it occurs. Osteoporosis is a silent disease, as patients typically do not have symptoms. This is a bone disease that develops as bone mineral density and body mass decreases, or when the quality or structure of bone changes. This can lead to decreased bone strength, increasing the risk of fractures. Persons at risk for osteoporosis: women and men of all races and ethnic groups. It can occur at any age, but typically the risk of development for the disease increases with age. For women, the disease process usually begins 1 to 2 years prior to menopause. A hysterectomy at early age in ethnic groups of non-Hispanic white women and Asian women are at an increased risk. This is a preventable disease. During the spine encounter, should it be discovered that you have osteoporosis, it is imperative that you see your primary care provider for treatment. Spine surgeries. Before continuing, please ensure you know what specific surgery you are having. If you are having a neck or cervical fusion, you could be having an ACDF, or anterior cervical discectomy and fusion. This is in which an anterior or front incision to your neck is made, so a fusion can be placed to lock two or more vertebrae together in which no longer can move separately. This should decrease the amount of discomfort from the nerve compression. Titanium hardware, which is MRI compatible, is used to stabilize the cervical spine, consisting of screws, plates, and/or rods. This hardware remains in place. As you can see in the pictures, it dictates or shows the hardware separately on the left, where there's the plate and screws, the cage or the spacer disc used to restore disc height. Then you can see on the right what that post-operative or surgical view would look like. You may experience some discomfort or swallowing, hoarseness after this specific surgery due to the anatomy and location of the surgery. An additional cervical spine surgery option is a PCF, posterior cervical fusion. This is a technique of joining the bones in the back of the cervical spine together by making an incision to the back or posterior portion of the neck and placing hardware in, as shown on the right. Over time, these small bones fuse together to form an internal brace and stabilize the cervical spine, reducing painful motion or spinal cord compression. The titanium hardware, again, is MRI compatible, is used to stabilize the cervical spine, consisting of screws and rod. This hardware remains in place. Lumbar surgery, ALIF, ALIF, also referred to as anterior and posterior lumbar fusion with decompression, starts as a two-step surgery. First step is when an incision is made to your abdomen. The contents of the abdomen are carefully dissected away from the spine with the assistance of a vascular surgeon. A plate is then used to stabilize the front portion of your spine by the spine surgeon. Prior to surgery, you may have an appointment with a vascular surgeon to discuss the anterior approach of this surgery. Another 1 to 2 incisions are then made on the back and screws and rods are placed, adding increased stabilization of the spine. The fusion locks two or more vertebrae together, which can no longer move separately. This should decrease the amount of discomfort from the nerve compression. Titanium hardware, which is MRI compatible, is used to stabilize the lumbar spine, consisting of screws, plates, and/or rods. This hardware remains in place after surgery. Lumbar fusion, XLIF, XLIF, also referred to as lateral, anterior, and posterior fusion with decompression. This is also an additional two-part surgery. You start first laying on your side, where an incision can be made on your side just above the hip. Then a plate is used to stabilize the front or side of the spine. You're then flipped over to where you're laying on your stomach, where another incision is made on your back, and screws and rods are placed, adding increased stabilization to the spine. The fusion locks two or more vertebrae together, which can no longer move separately. This should decrease the amount of discomfort from the nerve compression. The hardware is titanium and MRI compatible that is used to stabilize the lumbar spine. It consists of screws, plates, and/or rods. This hardware remains in place after surgery. Lumbar fusion, TLIF, TLIF, or transforaminal lumbar interbody fusion, is an approach in which an incision is made to your low back to access diseased or damaged discs for removal to reduce pressure. An implant is placed to restore disc space or height, and then a screw and rods are placed, adding increased stabilization to the spine. The fusion locks two or more vertebrae together, which can no longer move separately. This should decrease the amount of discomfort from the nerve compression. The titanium hardware is MRI compatible and used to stabilize the lumbar spine and consists of screws, plates, and/or rods. This hardware remains in place after surgery. Medications. It is important that your medication list is up to date so the pre-admission nurse can review which medications to stop and when prior to surgery. You will be required to stop any non-steroidal anti-inflammatories such as ibuprofen, naproxen, Celebrex, Mobic, and Idocaine 7 days prior to surgery. This list is not all-inclusive, so please refer to your surgery scheduling letter for additional drug names. You may resume non-steroidal anti-inflammatories 6 weeks after a lumbar fusion. You will need to stop taking aspirin and any anticoagulants, including Coumadin and Plavix, 5 to 7 days prior to surgery. Again, this list is not all-inclusive, so please refer to your surgery scheduling letter for additional drug names. Lovenox is required to stop 48 hours prior to surgery. Any blood thinners or anticoagulants may resume 72 hours after surgeries. Specific blood thinners may require cardiac clearance to stop them prior to surgery, and your surgeon should be reaching out to them to ensure they can be stopped. You should not take any diuretics the morning of surgery, such as Lasix or hydrochlorothiazide, unless instructed otherwise by the pre-admission testing nurse. You should not take any ACEs or ARBs the morning of surgery. These are antihypertensive or blood pressure medications. Examples include lisinopril, Lotorol, Cadopril, Latinosin, Minopril, Prenazide, Atenoside, Venocar, Diovan, and Avalid. Diabetic and weight loss medications prior to surgery. Diabetic patients should not take any oral hypoglycemic agents and or insulin products the morning of surgery. Metformin is the most vital to not take the morning of surgery. If you are diabetic, let the pre-op team know so that way they can give you instructions on how to treat high or low blood sugar the morning of surgery. Diabetic weight loss injections such as Trulicity, Ozempic, Wegovy, Mounjaro, Victoza. This list is not an all-inclusive list. Please refer to your surgery scheduling letter for additional drug names. If you take any of these medications daily, do not take them the day of surgery. If you take weekly, do not take 1 week prior to surgery. If holding longer than 1 week before surgery and you take the medication for diabetes, you may need to contact your endocrinologist to bridge the diabetic therapy. If you have any additional questions, please contact our pre-admission testing clinic at 573-681-2900. Home safety recommendations. Prior to surgery, there's a few things you should do to get your home ready for coming home after surgery. Remove any tripping hazards, such as throw rugs. Place frequently used items within easy reach. Make sure you have a clear pathway to the kitchen, living room, bedroom, and bathroom, and secure any electrical and or phone cords. Ensure you have adequate lighting for moving around your home at night. Go grocery shopping and prepare meals ahead of time and freeze them if able. Refill your routine home medications. These last two, for going grocery shopping and refilling your routine medications, we encourage. That way when you get home after surgery, you can focus on staying home for a few days instead of worrying about running errands. Arrange for help. Talk with your family or friends to help during the recovery period with driving or daily errands. You will have a 10-pound lifting restriction, so someone will have to help you lift items if needed, or ensure you have them moved prior to surgery. Pets. Do not allow your pets to jump up on you after surgery. Be mindful of pets getting under your feet when you're using your walker or you're up and moving about. And if your pets sleep with you, they need to lay on top of the bedding and ensure that they are never near your incisions. So if you're going to go change your dressings, make sure you go to the bathroom, wash your hands really good, and then change the dressings. Anesthesia. The general anesthesia is given to you during your surgery process. General anesthesia affects your entire body. It acts on your brain and nervous system. Under general anesthesia, you are completely unconscious and unable to feel pain during the medical procedure. General anesthesia is usually used as a combination of intravenous or IV drugs and inhaled gases. General anesthesia is more than just being asleep. The anesthetized brain does not respond to pain signals or reflexes. The effects of anesthesia. Post-op delirium includes confusion, trouble remembering things, or difficulty focusing, or even unaware of your surroundings. It can come and go and may last up to a week after surgery. This is another important reason why we recommend you having a support person during the time of surgery and after surgery, because they may help you refocus or remind you of your precautions after surgery. Post-op cognitive dysfunction. This is a more serious condition in which can cause long-term memory loss as well as decreased ability to learn or concentrate and think. Conditions which increase this risk are heart disease, lung disease, Alzheimer's, Parkinson's, and a previous stroke. It is imperative that when providing your health history and current medications, you provide accurate information, as this can affect anesthesia. After general anesthesia, you may have some nausea. If nausea is persistent, please let your nurse or spine care team know, and if applicable, medications be given or prescribed. You can expect pain or discomfort to the throat from intubation that can last 2 to 3 days after surgery. The anesthesiologist and their team will see you the morning of surgery. Pre-bathing instructions prior to surgery. Pre-surgical soap and instructions will be given to you at your pre-op or PAT appointment. Remember to change your sheets prior to starting the prep, including having fresh pajamas for after your shower. Once the prep has started, do not apply any lotions, creams, or pain lotions. Take a shower using the pre-surgical soap provided to you during your PAT or pre-op appointment. All spine surgeries must use. Bathing steps or instructions. Wash your hair, face, and body as usual with your normal shampoo and soap. Rinse your hair and body thoroughly to remove all soap. Turn off the water. Apply the chlorhexidine soap with a clean, wet washcloth and apply from your neck down, avoiding face and genital areas. Wash your body thoroughly but very gently for 5 minutes. Pay special attention to your surgical site. Do not wash with regular soap after chlorhexidine soap is used. Turn the water back on and rinse your body thoroughly. Pat your body dry with a clean towel. After your shower, do not apply any lotions, creams, or powders. You've made it to the day of surgery. When you arrive to the day of surgery, make sure you park at the outpatient entrance. If you arrive between 5:30 to 6 a.m., please take elevator B directly to the same-day surgery check-in desk on the second floor. If you arrive the times after 6 a.m., please go to registration, which is located to the right after entering the building through the outpatient entrance. After registration, take elevator B to the Health Plaza to the second floor and proceed through the double doors to the same-day surgery check-in desk. After stepping off the elevators on the second floor, you will proceed straight through the double doors and follow the long glass corridor on the right and arrive at same-day surgery. At that desk, you will be greeted with either a sign that says to pick up the phone and call the charge nurse, or a patient liaison will be there to assist you and your family members. This is the same-day surgical area waiting center. So this is where your family members will be during the surgical process when they take you back for surgery. After you've been checked in at outpatient registration, then you go upstairs to the second floor. You will be placed in a pre-op room. This is at the point where the surgeon will come and talk to you, make sure you don't have any questions, concerns, and then will mark your surgical site. The nurses will get you ready for surgery. They'll put you in a gown. They'll start IV, any antibiotics, and then all spine surgeries will have foot or calf antithrombic pumps on before and after surgery. These help prevent deep vein thrombosis or DVTs during and after surgery. After the surgery, you will wake up in the PACU or post-anesthesia recovery unit. At this point, the surgeon will speak with the family members to let them know or update them on the surgery process. You can be in the PACU for about 1 to 2 hours depending on how you recover, how you're doing, how you wake up, until you're transferred to the next phase of care. Where you are recovered after surgery. One of the following two options are dependent on the type of surgery and insurance authorization obtained prior to surgery. This is typically shared with you by our referral coordinator team. In same-day surgery recovery or an outpatient surgery shown in the top two right pictures, you would be discharged after surgery as long as you're recovering well. In the hospital patient tower or inpatient pictured on the bottom right two pictures, you would typically stay 1 to 2 days after surgery depending your recovery. In both options, you will have a private room. The expectation is that we have you up and walking within 2 to 4 hours after being transferred from the PACU, whether that be back to the outpatient surgery center or the inpatient surgery side. This is also when your precautions will begin. Lumbar precautions. Remember, no BLTs. That acronym stands for no excessive bending to your low back, no lifting, pushing, pulling greater than 10 pounds, and no excessive twisting to your low back. After lumbar surgery, it may be required that you use a walker for safety as needed. The use of an abdominal binder is required for those patients who had an ALIF approach or abdominal incision during their surgery. For those patients who are required to wear this, they will wake up from surgery with the abdominal binder already on. It is required for you to wear the abdominal binder for 24/7, 7 days a week until the abdominal incision is healed or you've been seen in the office with abdominal staples removed. You may remove the abdominal binder for showering, dressing changes, and or if you're laying down at night. So we really want you to wear that abdominal binder when you're up and moving, up in the chair, especially when you're walking to help provide support to the abdominal incision. You may wear a t-shirt under that abdominal binder to avoid any skin irritation or rubbing. Cervical precautions. Remember the acronym no BLTs? The same applies, but to your neck area. So no excessive bending to your cervical or neck spine, no lifting, pushing, pulling greater than 10 pounds, and no twisting left or right to the cervical or neck area. The use of a cervical collar after your cervical fusion is determined by the numbers of levels affected during surgery. For an ACDF involving 1 to 2 levels, you will be placed in a soft collar that can be worn as needed for comfort during the 12 weeks of recovery. For an ACDF involving 3 to 4 levels, you will be placed in a hard cervical collar that must be worn during the entire 12-week recovery process. You may take the collars off during showering and dressing changes. Proper body mechanics and precautions. These are just some tips and tricks that may be able to help your transition home after surgery. So sleeping on your back, you may place pillows under your knees and under your head to help provide support where needed. If you sleep on your side, you can place pillows between your knees and again underneath your head to provide support. You may also feel more comfortable sleeping in a recliner because it puts your neck and your low back at different positions than it would be laying down in bed. Log rolling is indicated by the middle picture. It's just an example of how you can properly get out of bed by keeping that spine aligned. And then some tips with getting dressed are indicated on that right picture. You don't think about bending down to put your socks or shoes on. So this is some tips and tricks again, how you can lay in bed or sit at the edge of the bed to help you get dressed. Proper body mechanics and precautions continued. Again, this is just showing in that top left picture how the patient is squatting down, holding that basket close, and using her leg muscles to stand up. I hope her laundry basket is less than 10 pounds, but she's using proper body mechanics to keep her neck and her low back straight or within her precautions. That middle picture just shows bending at that low back. So instead of bending at her low back, she is squatting, keeping her feet shoulder width apart to help her pick up the item she dropped. And then getting in and out of your car. Lower yourself onto your seat, scoot back, then bring your legs in one at a time to help you transition into the car without twisting to your neck or back area. Pain is an expected part of surgery, and having no pain is an unrealistic expectation after surgery. During your recovery process, you will hear our team ask you on a scale of 0 to 10, what would you rate your pain right now? Please be honest with your team and your family members that are helping you at home. That way they know if it's time to give you an additional pain medication, are the medications that you're using helping, and remember your alternative measures such as repositioning, using pillows, ice, getting up and walking. If you're having concerns managing that pain at home or even while you're here at the hospital, pass that along to the surgical team or the nurses that are helping take care of you so we can try the next plan of care or next plan of action to help you get more comfortable after surgery. As you continue to recover, that pain level should continue to increase with recovery. Discharging home after your surgery. Discharge instructions and handouts will be given to you by the orthopedic staff to ensure a successful discharge and to address any additional questions or concerns. If you are scheduled for a same-day surgery, the outpatient nurses will discharge you once you are awake enough and recovered well enough from your surgery. If you are scheduled to stay or an inpatient surgery, you will discharge typically 1 to 2 days after your surgery. If you are scheduled for an inpatient surgery or will stay the night after your surgery, case management will see you prior to discharge. They can assist in arranging a walker, home health if you need additional assistance at home, or if you're requiring a SNF or a skilled facility, they will help arrange this. Showering instructions: you may shower 2 days after cervical surgery or 3 days after lumbar surgery. The first shower, leave the dressing on. After showering, remove that dressing, pat the area dry, and then replace with another dressing, gauze and tape. Subsequent showers should be every other day, and the dressing may be removed to allow water to flow over the surgical site. You may need additional assistance with showering, such as a shower chair, a bathing sponge, or the assistance of your family members or loved ones. Wound incisional care. Always remember hand hygiene prior to touching your incision. Whether you, the patient, are changing the dressing or you have a family member or support person, they always need to wash their hands prior to touching that incision to help prevent infection. Your dressing is just paper tape and gauze, 4x4s that you can purchase at your local pharmacy or store. And then after surgery, you may notice something called a seroma. Sometimes this develops 5 to 7 days after surgery. A seroma may develop on the back of your incision or your cervical incision. This is a pocket of fluid which tends to collect underneath the skin after surgery. As you become more mobile, your body will absorb the fluid and or a leak from your incision site. If a seroma should appear, please call the office and speak with the spine team nurse. New medications after surgery. Prescriptions will be e-prescribed to the Health Plaza Pharmacy or to the pharmacy of your choice to help reduce pain after surgery. Please call your surgeon's office to discuss pain control and or the need for additional refills. Ensure you're taking all medications as directed and remember your alternative measures to help control pain, such as repositioning, ice, and walking. Driving after surgery. You may drive when off narcotic medications and when cleared by your surgeon. Returning to work. We ask for a minimum of 2 to 3 weeks after surgery, depending on the type of job that you do and when you're released by your surgeon. This depends on the surgery you're having and the type of work you do for a living. Follow-up appointments. Please refer to your discharge paperwork for scheduled follow-up appointments within 2 to 3 weeks of discharge. Outdoor activities to avoid for a minimum of 12 weeks include mowing the lawn, riding a tractor, riding in a boat, riding a motorcycle, using a chainsaw, or golfing. And remember your precautions for all cervical and lumbar spine surgeries. No BLTs, bending, lifting, pushing, pulling greater than 10 pounds, or twisting. You may contact your surgeon's office or send a message via patient portal with any questions or concerns. You should contact them immediately if you have any of the following: new changes in sensation or weakness, any signs of infection, temperature greater than 101.5 degree with or without chills greater than 24 hours, any redness, swelling, or warmth around the incision, any increased yellow or cloudy or foul-smelling drainage from your incision, or if the incision separates, increased in pain, any bowel or bladder changes, any signs of blood clot, which include pain, swelling, or redness or warmth to your calves. If you experience any of the following, please call 911. Difficulty breathing, shortness of breath, chest pain not relieved by rest or medication, disorientation, dizziness, and fainting. Remember, your surgeon and his team is always here to help you, so if you have any questions or concerns, please don't hesitate to reach out. Thank you for watching the Spine Education PowerPoint. Please contact your surgeon's office with any additional questions or concerns.